It is just a huge honor for me today to be podcast interviewing Dr Gerson, MD, MSc, FACG. I'm so excited to get her on the show. She's a board-certified gastroenterologist practicing at California Pacific Medical Center in San Francisco. After completing her residency in internal medicine at CPMC, Dr. Gerson trained in gastroenterology at Stanford University, where she was a faculty member and clinician for 16 years. She is a nationally recognized researcher and caregiver in the field of general gastroenterology, including colorectal cancer screening, gastroesophageal reflux disease, GERD, gastrointestinal motility disorders, capsule endoscopy, gastrointestinal bleeding. And I wanted to get her on the show because on Dentaltown, if you do a search for GERD, there's a lot of posts, there's a lot of information, and I'm wondering, how much of it is quality information. So I thought I'd find the smartest person I could in the world to talk about it, and she's here today. So what do dentists need to know from your perspective about what you study all day long?
Well, first of all, thanks so much for having me on this show. I think that there is some evidence linking heartburn to dental erosions. And just to tell the audience, the typical symptoms of gastroesophageal reflux disease in patients are sensation of burning in the chest after eating, fluid coming up into the throat after eating as well. And sometimes this occurs when patients are lying down at night trying to go to sleep, or it may wake them up from sleep as well. Some patients also have trouble swallowing, their food gets stuck, they may have chest pain, and some of them also complain to the dentist of like throat pain, hoarseness, laryngitis, and so forth. Now, where this gets a little bit murky is that dentists will notice erosions on the teeth. As far as I know, there's no real validated scale to date to determine how severe these erosions are. But there has been some data linking the presence of erosions to heartburn, particularly in patients who have the symptoms. I think the bigger question at this point is if the dentist finds erosions and the patient has no symptoms, how likely are they to have a connection? So that needs to be studied further. But that's where the connection came in, is dentists will do a dental exam, find erosions, and then ask the patients about these symptoms and try to determine if there's a correlation.
So would the erosions be more likely to be on the inside of the teeth where stuff's coming up from the esophagus, or on the outside of the teeth where it touches the lips and cheek?
Yeah, I'm not entirely sure. I mean, I think when I read the literature, there's been erosions, described anywhere in the teeth, and I'm not exactly sure if there's a particular pattern that's specific to reflux disease.
So what do you think is causing GERD?
Well, so the main cause of GERD in patients is that the lower esophageal sphincter muscle, which is between the esophagus and the stomach, starts to relax inappropriately in certain subjects. We don't really know why this occurs. There are certain well-known risk factors like weight gain. If you gain more than 15 to 20 pounds, that's definitely a risk factor for heartburn. Certain lifestyle factors like eating late at night before you go to bed. We tell patients, don't eat 2 to 3 hours before you go to bed. Eating foods that are high in fat also before you go to bed causes the stomach to empty slower.
Do you have a hidden camera in my house? Because you're describing me fat, eat before bed. Are you just talking about me? What about the skinny people listening to this show?
Yeah, I mean, there are skinny people that come into my office and they really don't have any of these risk factors. They eat healthy. They don't eat late at night. And what I have a way of studying their sphincter pressure called manometry, which is when we put a catheter down and actually, measure the sphincter pressure. A lot of times those patients have normal sphincter pressure, but for unknown reasons, their sphincter starts relaxing more than it should, and that leads to reflux disease. So it's not completely understood, why some of these patients get reflux disease.
So when you eat a big meal before you go to bed, how long should you stop eating before you go to bed to have your stomach empty enough to where you're not risking it regurgitating back up into your esophagus?
We tell patients typically 3 hours.
3 hours.
And try to eat food that is less fat at nighttime. And try to eat earlier dinner. And then go to bed maybe 3 to 4 hours later.
So I'm pretty sure I read the label. I'm pretty sure whiskey has no fat in it.
Well, the other thing is that If you go to Google, go to the web, there's a lot of foods listed that patients with GERD should avoid. They list spicy foods, orange juice, tomatoes, caffeine, alcohol, tobacco. The question is, how good is the evidence that patients should avoid all those things? And there really is not that much evidence that avoiding all those foods is going to cure your GERD. Definitely eating late at night is a risk factor. Weight loss has been shown to be effective. And for patients who wake up at night, there is some evidence that using a wedge, like made of foam, that's about 6 to 8 inches, is helpful in reducing those kind of symptoms. There were some studies looking at smoking and alcohol, showing that those agents may relax the sphincter further. But there's really not a lot of good data that elimination of all these things will cure GERD completely. My patients in my practice tend to complain about red wine more than anything else as an aggravating factor. So I tell patients if they're going to go drink some wine, definitely take some medication before they do that. So I think in terms of diet, it really depends on what provokes the patient. And if they eliminate those foods and it doesn't make a difference, then I would just tell them to eat, relatively normally, as long as it's healthy.
I've had a patient for 30 years, and due to HIPAA, I can't say his name, Bernard Wells, and he was an engineer, and he had this GERD, and he, in his engineering mind, he propped up the front of his bed on 2 red bricks, and
Right.
so it was at an angle, because in his mind, the incoming valve into the stomach should be higher than the exiting valve into the intestine. And he swears to everyone that as soon as he put the front 2 pegs of his bed on 2 little, whatever thick a red brick is, that it went away. Have you ever heard of anything like that?
Yeah, I mean, there have actually been randomized controlled trials where patients were randomized to either bricks or wedges, where the head of the bed was elevated like 6 to 8 inches. And it was effective for patients who have nighttime symptoms. So these are patients that, feel acid coming up when they're trying to lie down at night or are awakened by acid, but that is effective for those patients. And that's been shown in randomized trials. The problem with all this other stuff, the food avoidance, there really hasn't been a lot of data generated to prove it, like there was for the head of bed elevation. So I believe it in that patient.
And back to geriatric medicine, I'm in Phoenix. There's a lot of retired senior citizens that moved here from, I think 10% of Phoenix is retired from Canada, the northern Midwest, but you see all these older people that, like, they'll tell you that, yeah, I have indigestion, but I take a couple of Maalox 2 or 3 times a day, and I've done that for 20 years. But you're looking at the bottle of Maalox, and it says do not use longer than 2 weeks. And then you have
Right.
these patients that have been eating this, and then there's also a lot of patients that are, when you do their health history, they're on prescriptions for this type of stuff. What do you think about these over-the-counter and prescription medications for this type of disease?
So first of all, let's talk about the antacids. There's Tums, which you should know has calcium in it, which can cause constipation. Then there's Mylanta, which has magnesium, which can cause diarrhea. Those agents are very effective. They work very quickly. The problem is within about 45 minutes, they wear off. So what's important to ask people is how many times a day are you taking those? And that'll kind of be as a marker for how severe their disease is. But those agents are effective. You can add them onto other medications that we give patients. But the problem is sometimes patients are just taking so much of them that they can get side effects from them. Then we have things like the H2 blockers, like Pepcid, Zantac, Tagamet. Those are all also over the counter. In general, they're effective. They can be taken, at bedtime or as needed. And patients with milder disease can be controlled with those drugs. So it's worth definitely giving those a try. Then we have the proton pump inhibitor drugs, which are now pretty much all over the counter. There's Prilosec, Prevacid, which are known as omeprazole, lansoprazole. There's Protonix, which is pantoprazole. There's Nexium, which is esomeprazole. And these drugs work by mainly turning off the pumps in the stomach to secrete acid. So the first thing is that patients really need to take those drugs about 30 to 60 minutes before meals, because if they take them after meals, it's too late. Those pumps are already making the acid, and they won't really work effectively. Those drugs are very effective, though. They're effective in reducing symptoms and healing erosions in the esophagus about 70 to 80% of the time, whereas the H2 blockers are only effective about 50% of the time. So if you have a patient who really has more severe symptoms, those are the drugs to go to. Now, one little trick is that if patients are cured with those drugs and feel better, they don't have to take them continuously. They can take them for 2 to 3 weeks at a time and then stop them and use them as needed. So that's kind of the spectrum of medical therapy that we have. Then I do have some very severe patients in my practice who have a lot of trouble swallowing and muscle difficulties. And we have some other drugs that are motility drugs that can help move the acid and the other contents out of the esophagus. So, in terms of side effects, I think what gets everybody very excited these days are when they look up proton pump inhibitor or omeprazole on the web, you get a series of things that show up like dementia, kidney failure, pneumonia, bone fractures, heart attacks, vitamin deficiencies. Most of these side effects do not have hard evidence behind them that they actually cause these side effects. So, for example, with bone fractures, there were some very nice 10-year studies done in Canada looking at women with osteoporosis and fractures and control groups, and they really couldn't show that these drugs alone cause bone fractures or hip fractures. That's the good news. Dementia, for example, is a state that takes like 20 to 30 years to form. And so what they do is they take these very large databases and try to link these drugs to dementia, but there's really no evidence that they cause dementia over time. There is some evidence that these drugs can cause certain infections like Clostridium difficile and other diarrhea-type infections. But most of these other side effects that you read about are not really hard proven in the literature. So in general, we have patients that have taken them for 30 to 40 years, and we know that they're safe. These patients don't get stomach cancer or any other major side effects. That being said, a lot of these patients don't want to take medications long term. So there are other ways to fix reflux too.
So when you're a dentist, you have a patient with GERD, who should they refer them to?
Well, they should probably refer them at least to an internist to get started on medication if the patient's having bad symptoms, and then to someone like me, a gastroenterologist. The tests I can do, so basically, if you have long-standing GERD, you're going to like this, and if you're a male over the age of 50 who has certain risk factors like long-standing heartburn, being overweight, being a smoker, possibly family history, you probably should undergo a one-time screening with a camera called an endoscopy to make sure you don't have anything precancerous in there called Barrett's esophagus. And if you have that tissue present, you should probably be followed a little more closely, and be on these proton pump drugs on a regular basis. So the gastroenterologist can more effectively work you up to see, what's going on inside, see if you have a large hiatal hernia, which is like a pouch in between the stomach and the esophagus that may want to be repaired. The other thing that I'm seeing a lot of nowadays, which has become much more prevalent for unknown regions, is something called allergic esophagitis. So we get these young patients that come in sometimes in the middle of the night with steak stuck in their esophagus, and they basically have food allergies that present with trouble swallowing and heartburn. And the way we diagnose that is by taking pieces of tissue from the esophagus. And if that's present, then we might treat them with inhaled steroids or some kind of food elimination. So the gastroenterologist can do all these kind of tests to determine, what's going on.
How many gastroenterologists are there in the United States?
I want to say there's around probably 15 to 20,000. So it's not that many.
Well, there's 19,000 towns, so that means probably all the dentists are within reach of a gastroenterologist.
Correct.
Yeah. And another thing I've noticed at a lot of dinners, when you're out lecturing, you go to dinners, it seems to be more common with older people that sometimes they, when they go to swallow, they have like a temporary spasm or something. What is that called? You know what I'm talking about?
Yeah. So I have special training in what's called pH testing and motility disorders. In other words, I can do certain tests on these people to see how well their muscles are working. And there is something called esophageal spasm that we can diagnose with a motility test. And what happens there is a lot of times the muscles, when you go to swallow, there should be like a nice wave coming down the esophagus. But in these people, about 50 or 60% of them have reflux. Basically, what happens is the muscles are contracting all at the same time and they're spasming. And we can actually treat those patients with medications like heartburn medications, nitroglycerin. Sometimes drinking warm liquids will do it also as well. So there are tests to diagnose, when patients have trouble swallowing that we can do.
So when you go into Dentaltown, there's a 250,000 dentists. They posted 5 million times, and I just went on that search bar and I put GERD, and it just goes on forever. I hope someday you really join Dentaltown and tell these people what you think of all their posts on GERD. You were telling me that you're thinking about rounding up some dentists to do something to study. What are you what are you trying to do?
Well, I actually looked in the literature, and we do tests called pH monitoring. One way to do this is to put a probe through the nose into the esophagus for 24 hours, and that would measure how much acid patients are having and how high it's coming up into the throat. And there have been some studies of a relatively small number of patients showing that if they have heartburn and dental erosions, that they are showing that those patients are refluxing into their throat, and there is a cause and effect association. Nowadays, I do something more often called wireless pH testing, where during the endoscopy I can stick a little probe into the esophagus, and that can actually measure your acid output for 4 days and see how much reflux you're having for 4 days. So I think that test might be useful in patients who the dentist sees who have erosions but don't have any reflux symptoms. So the main question is, how many of these patients that the dentists see that have erosions really have reflux but aren't really reporting it to the doctor or reporting the symptoms? So that would be an interesting study to do.
It'd be. I just emailed you a big thread on GERD to your email account. I wonder if this is. I wonder how accurate the dentist's health history is, or if we should just have an additional health history if we suspect GERD. Because I was reading on your stuff that says approximately 7 million people in the United States have some symptoms of gastroesophageal reflux disease, GERD, and 60% of the adult population experience some type of GERD within a 12-month period. Is it imperative for patients to understand the following: the contributing factors to the condition, the elements that may agitate it, the latest treatment advances available, and sometimes I'm so glad I got you on the show, because sometimes I wonder when we think it's GERD if we even have the right diagnosis.
Yeah, so the actual figures that we cite are about 40% of Americans have GERD at least once a month, and then it's about 7 to 10% at least weekly or daily. So you're talking about a huge number of patients.
40% once a month.
Right.
And what was the other number?
About 7 to 10% on a daily basis and also on a weekly basis.
Wow. So 1 in 10 every day and 4 in 10 once a month.
So the real question, I guess, is, are dentists asking patients about these symptoms appropriately? And then the other question to ask you, which I don't really know, is if the dentist sees an erosion, are there certain scales of erosion that might point to GERD? In other words, does erosion have to be a certain severity? Has someone come up with, different ways to grade the erosions to say this patient is more likely to have GERD? That kind of thing.
So that's what you're wanting to do? You're wanting to create a scale to measure erosion for GERD?
I think it'd be interesting. And I think the real question is, if you go to see your dentist and your dentist tells you you have erosions, but you don't really feel any heartburn, should you go see somebody like me to do testing and see if you have what's called asymptomatic GERD? Which, when we find this all the time, there's patients who basically don't report symptoms to their doctor, but when we test them, they end up having GERD. It's called silent GERD. So that would be interesting to do in the dental population, which I don't think has been done before.
So should these dentists, if they're interested in this, you're talking to a bunch of dentists commuting to work. That's why podcast is so successful, because it's taking out radio. They're tired of listening to politics and all that on the radio, and so driving to work. So if this fascinates them, should they go to your website, laurengerson.com, or how should they get in contact with you?
Yeah, they could definitely go to my website. They could get in contact with me on Twitter because I'm on Twitter as well. I'm also on Facebook. I have a Facebook page, Lauren
What's your
SD,
Twitter? At what?
at L Gerson.
L Gerson. And is that why you went into GERD because your last name was Gerson? Is there any association between GERD and Gerson?
No, I had a mentor when I was about 15 to 20 years ago who was very interested in GERD, and because of this mentor's, enthusiasm, I became interested in it. So nothing to do with the name.
That is very cool. That really is very cool. It's amazing how that works out in life. How just the right place, the right time. Um, so, do you want him to email you, or do you prefer the other two?
That's a good question. Well, they could also email me. The email is lgersonmd@yahoo.com. That would be fine as well. And, I think it'd be very interesting to take a bunch of patients that they think have GERD but don't have symptoms and then somehow study them with pH testing and see how many of these patients actually end up having GERD. That would be interesting.
Now, would the dentist pH test them, or would the gastroenterologist do it?
Yeah, the gastroenterologist would do the testing.
The gastroenterologist. I'm seeing if I gotta find you on Twitter. So it'd be how do I do it? So you said it was at
L.
L Gerson.
Right. But maybe one of the first things we
At
should
L
do,
Gerson.
right? We
I
have
already follow.
questions.
I already follow you, but you don't follow me. I'm going to retweet you right now. Which one do you want me to retweet? Does administration of capsule endoscopy in the emergency room work? Listen to the latest podcast. Next one, gastric cancer may be more prevalent than esophageal cancer. My latest GIE podcast. So you're a podcaster too.
Yeah, I actually am an associate senior editor for a journal called Gastrointestinal Endoscopy, and I do monthly podcasts for that journal where I interview patients, interview doctors about their articles, all kinds of different topics.
Will you? Well, if you ever do a podcast show for that magazine, and you're talking about dentistry and GERD, email it to me, and I'll or you can post the link to the show on Dentaltown, or I'll push it out on my Twitter. I'll retweet it or whatever. But again, because it's a real honor to get you on the show, because I don't think dentists, and most of what we learned in GERD was probably in dental school, and like I graduated 30 years ago this May 11th. So
Right,
the
right.
guy who taught me about GERD's probably not even alive, and so it's nice to have a nice update. And if you wanted if you started a thread and you said help Dr. Lauren Gerson, MD, MSc, gather pictures for GERD erosion or whatever, I guarantee you my homies will give you 1,000 pictures, and I mean you could create this all on Dentaltown in a week.
Well, the other interesting thing, that would be very interesting. The other interesting thing would be that we have questionnaires that have been, validated for heartburn. So what if all these dentists gave patients questionnaires when they walked in? Would they be more likely to say, yes, I've got these symptoms or not? That would be very interesting, is to see, what percentage of patients coming into the dentist actually have these symptoms when you ask them formally with questionnaires. So we could definitely, provide the questionnaires and people could fill them out.
That would be amazing. And that's the big talk. It seems like the big talk in dentistry for the last 5 years is the oral systemic link. It's kind of like dentistry is the red-haired step bastard child of medicine. I mean, we're not real doctors. We're dentists, vets, chiropractors. And now it seems like they're starting to trace so many things in the mouth to the rest of the body. And the big push in dentistry is the oral systemic link, trying to realize that this gum disease and the bacteria in the gum disease is showing up around the rest of the body. So there's a huge interest in dentists to get reconnected with the rest of the body. Do you see that in other sectors of healthcare?
Well, one of the main things we're trying to tackle now is the whole microbiome story. So, we have patients coming in who have bloating and different bowel dysfunction. And one of the tests I do is I actually measure whether they have what's called bacterial overgrowth syndrome. And if they do, a lot of times if we treat them with antibiotics, certain symptoms will get better. So there's a huge explosion in that area that we're trying to understand better. Other areas, for example, is for patients who have refractory infection in their colon, like Clostridium difficile infection. You might have heard about fecal transplants, which have been also very effective. So there's a lot of work being done about what's good bacteria, what's bad bacteria, how should we study it, whom should we treat, and we're just starting to get into that.
I posted about fecal transplant on Dentaltown a couple years ago, and most people thought it was a joke, but it's a serious thing where they're talk about a fecal transplant, because there's people listening saying, "Did he just say fecal transplant? What is it? What is a fecal transplant, and why are people doing it?"
Well, so there are
And
some
more interestingly, how is it actually done?
there are some patients who have this infection called C. diff infection, which traditionally people get from taking antibiotics, but now they can also get it from the community. And we usually treat it with antibiotics, but in very severe cases, patients have lost their colons, have had to go to surgery because their colons get very large and infected, and they can die. So the fecal transplant essentially started out where family members would donate their stool. And one way to do this is to take a colonoscopy scope and actually infuse the stool throughout the colon. And that's been effective. Another way to do this is to put a tube down into the stomach and to infuse it that way. But your listeners will notice that there's companies now like the Oral Microbiome that are making capsules composed of different type of stool that's collected, where patients can swallow these capsules. So it's getting kind of more organized, site and order these things, and they can be infused. But the method of infusing it through the colon with a colonoscope by a gastroenterologist has been shown to be the most effective way to cure infection.
So, do you do a lot of work with colon cancer too? I mean, is that part of your?
I do colon cancer screening as well.
And what do we dentists need to know about that? What about all the old dentists listening to you right now? Is it still that you wait till you're 50, and then when you're 50 you get your first colonoscopy?
Yeah, I mean, in most cases, unless the patient comes in and they have rectal bleeding or they have, first degree relatives who've died of cancer in their 50s, most patients will start at 50. Obviously, if somebody comes in their 20s or 30s and they're bleeding, we'll do it earlier. Colonoscopy is still really the most accurate way to diagnose polyps, which can go into cancer. The other way to screen is by doing a stool test called a FIT test, fecal immunohistochemistry testing. The downside to that is you have to do it every year, so it's a lot of testing. But that's also quite effective. There's also a DNA test that has been called the Cologuard. It is more expensive and tends to have more false positive results. And I am doing some research on little capsules, which are cameras that you can swallow that eventually can visualize the colon too. So,
so what do you think of these things you're hearing about now, like 23andMe, where people are sending in 3 cc's of saliva and getting their DNA sequence, and then they're putting it in a bank? Do you think, like, okay, so I did the 23andMe,
right.
out of morbid curiosity. Do you think eventually, like, all that DNA will be in a data bank, and then someday when they discover other genes, that they'll actually be calling you back and saying, "Hey, we just discovered this gene causes this disease, and you sent in your DNA years ago, and you need to check for this"? I mean, do you think it's headed that way?
Well, potentially. I mean, one of the problems we have when patients come in and they say, "Oh, I have a family history of colon cancer," is trying to figure out if they're really at risk genetically. So I think that's a situation where if they get tested and they have a positive gene, then we may want to screen them more effectively as well with that test. The problem is, though, with colon cancer screening is 40% of Americans still don't undergo testing. So we have a problem more with getting people to undergo the testing rather than trying to find patients who actually have polyps, which we're pretty good at most of the time.
Yeah, I told the man, I'm 54, so I had it when I was 50. I told him, I said, all I want to know is I don't want to know how far you're going to go in there. But now that it's 4 years later, how far do they actually go in there?
Well, so when you have a colonoscopy, technically the exam should go all the way to the appendix. You should see the appendiceal orifice. And then sometimes we also go into the valve and go into the small intestine. But a really good quality exam should go all the way to the appendix and then should come out very slowly and take a look behind all the folds and look for polyps.
So how many feet is that?
It's about 3 to 4 feet in most people.
3 to 4 feet?
Yeah.
Yeah, that's probably something you should not put on the brochure if 40% of Americans won't do that. So do you think you're gonna start a thread on Dentaltown and try to get pictures of erosion and GERD? Do you think this is a project that you're gonna do?
If you give me some instruction about the best way to do it, I'd be happy to do it. Yeah.
Oh yeah, just go to dentaltown.com and then we'll
Right.
just you got to register, so we got to make sure you're really a doctor and not from 2020 or 60 Minutes or any of that stuff. And yeah, I think this is going to be a really fun deal. So we talked about GERD, you talked about colorectal screening, you talked about a lot of stuff. Is there any other areas that you do that you think dentists would find interesting, or what other information you think a dentist needs to think about more?
Well, some of these patients with GERD don't want to take medication. So we should talk about what are the other options for them. So traditionally, there was a surgery that people had called a Nissen fundoplication, where the surgeon went in. Now they can do it laparoscopically, and they basically wrap the top of the stomach around the esophagus. It's a very effective operation. Most patients are off their medications for up to 10 years. But the problem with that operation is some patients get trouble swallowing and they feel bloated and so forth. So a lot of the surgeons are now kind of turning away from that operation unless patients have very large hernias that have to be fixed. There are some new things on the market. One of them is a magnetic device called the Lynx device, which is also put in laparoscopically. It's actually put in where the sphincter is. And when you swallow, the magnet relaxes and opens up, and then the rest of the time it stays closed. It's relatively new. I mean, we have data up until about 5 years showing that it is effective, but I'm not sure exactly how long it lasts in most patients. So that's an option. And the other option is something called the TIF device, transoral incisionless fundoplication, which is done without any surgery. So this is basically a device where it's put into the stomach, and the tissue around the sphincter is grasped, and then there are these fasteners that are inserted through the device that essentially create a wrap and make the what do you call it, the wrap area tighter around 270 degrees. So what's useful about that is that patients can get relief of heartburn, but a lot of times don't have the gas bloat syndrome and the other complications. And for that device, we have data, again, around 3 to 4 years showing that it is effective. So, we are making progress with new devices so patients can get off medication. I can't always tell patients how long the effect will last for, but there are some other options for patients who, don't necessarily want to stay on medications long term.
So you got out of Princeton University in 1986. I don't think there's anyone in my pedigree that could get accepted to Princeton. And then you went to Stanford, and that's like, what do they accept? Like 1% of a million. My God, you're a really, really smart person. I mean, you just can't go to Princeton and Stanford without being a brainiac. Would you agree?
Thank you. Well, it's gotten very difficult to get into these schools now. In fact, my husband went to Princeton, but we know a lot of couples who their children can't get it anymore. It's difficult. The one piece of advice I would tell people is if you want to be a doctor or even be a dentist, take advantage of these schools if you can get in and do something different. So I was actually a French major as an undergraduate and still speak French. And I think it's worthwhile to try to diversify yourself.
Does your husband speak French?
He does. He does.
Is he from like Montreal or you
No,
guys?
no, we're just both Americans that like French. We're Francophiles. But
Wow, that is amazing. I want to ask you one observation. I got out of school in '87. You got out of Princeton in '86. Was it a man's profession in healthcare in '86 and '87? And is that different as for an MD? Has there been more women becoming MDs in 2017 than in 1986?
So I think that the current data shows that about 50% of medical schools have women enrolled. But by the time you get to my specialty, gastroenterology, we only have about 20% women. And, even fewer that are doing academic type of research like I do and who are in the leadership positions. So we still have an issue with women specializing. Now, obviously, in certain fields like pediatrics and OBGYN, there are more women, but there's certainly fields like mine where it's still male dominated.
So what are the female dominated? OBGYN, pediatrics?
Pediatrics, internal medicine, more and more. Those are the major ones.
I'm going to ask you a very political incorrect question because it is Dentistry Uncensored. And Ryan, if you just say pass, we'll just edit out. But um, why do you think when you go around the world to the most developed countries in the world, Canada, Australia, Germany, Singapore, they all have a national healthcare system for half the cost? But living here in America, I mean, the healthcare, it's twice as expensive and it's so politically crazy. Why do you think it's such a political m- quagmire in the United States, but not? You said you're a Francophile. It's not a quagmire in France.
Well, I was
It's
in
not
London.
in Canada. Why
Yeah,
is why? What are your thoughts on that?
I was in London 2, 3 years ago. First of all, you don't see any advertisements on any trains or buses or when you're driving for any kind of drugs or medical treatment. So we spend a huge amount of money in this country on advertising. Anywhere you pick up, even on TV, there's advertisements for antidepressants and all kinds of medications and sexual dysfunction. That's a bunch of our costs. Number two is, when you land, let's say in Las Vegas, all the posters on the road are all for lawyers who are going to, take care of medical malpractice issues. So we have a big legal culture in this society that also drives up costs significantly. That anytime patients want to complain, they can go to a lawyer, and that drives up costs. And number three is that our medications and some of the procedures, the costs are also not as regulated as are in those countries. So if you go to Canada, for example, there's certain drugs that I prescribe. You can get certain medications that are much, much cheaper here compared to the United States. And, we don't have a lot of control on those type of costs. So I think it's multifactorial, but it is very true. I mean, for example, in England, I know they spend a third of their GNP on healthcare costs, and they live just as long as we do. So you wonder if we're spending money in the right places for the right reasons.
Yeah, the data is the data really shows zero correlation with how much you spend and how much longer you live. I mean,
Yeah,
just like you said, there's a ton of countries that anyone listening would like to go to on vacation where they live longer than us for half the price of healthcare.
right.
But when you introduce any of those things or those ideas in the United States, it's like you're from Mars.
We also do a lot of, probably unnecessary testing. I mean, we have a lot of patients coming in with abdominal pain who get 3 to 4 CT scans a year, which costs a lot of money. So, in general, we're not really controlling those type of costs, and they should be controlled. The other interesting thing, for example, going back to the GERD scenario, is if I do pH testing on people, and what's really useful information is if I find they don't have any GERD when I do a pH test. The data shows that 40% of those patients are still on anti-reflux medications despite having a normal test. So often it's difficult to get people to stop
Back,
medications if they're taking them already.
I think it's funny because you listen to people's words, then you watch their actions. So when you're on Dentaltown, and if you said you were holistic or a naturopath, you would just immediately be shown the door. I mean, they just wouldn't do that. But then when you listen to the doctor, the dentist talk, they don't want to be on prescriptions. They don't want surgery there. So their behavior is very holistic and naturopath, and they don't want to be on 10 medications when they're 65. Point being, you said pH. I know a lot of dentists where if you said you were a holistic dentist or a naturopath, they wouldn't listen to you. Yet they swear that by taking a tablespoon of white vinegar before they go to bed, that they have solved their morning gagging and GERD. What are your thoughts on that?
Yeah, I mean,
Is that
this is another area I'd love to study. I had a patient the other day who had a pH test with me, and she uses apple cider vinegar, which she swears by. She
right?
uses
That's what I'm talking about.
She uses ginger as well, and she uses over-the-counter pepsin supplements. I think the problem is there's a lot of these natural supplements that it'd be nice to study. There's not a lot of data whether they work, but patients do swear by them. That's definitely true.
I have at least a dozen patients who swear by a whiskey shot glass of apple cider vinegar before they go to bed, cures their morning gagging and all that GERD stuff, along with, and they'll tell you, They say that when they have it, it's because they ate a big meal before they went to bed, and or they didn't take their shot of apple cider vinegar. So
But
you think,
you'd think that the vinegar would make things worse, right?
yeah, I mean, yeah, yeah, I
So
mean,
there are definitely a lot of patients see that use over-the-counter herbs, natural medications. There's a huge push now for probiotics, which, unfortunately, we don't have a lot of evidence that they work. People spend a lot of money on them. So I think, it'd be important for us to try to get evidence in the future.
well, you and I, speaking about probiotics, you and I have lived through a period long enough to where first they thought ulcers were a surgery, and then they realized it was a bacterial infection. So, I
Right.
mean, we've seen these major shifts.
Exactly.
What was that, H. pylori bacterium or?
Yeah, so it used to, be thought that if you had an ulcer, it was all due to stress. Then, of course, the Australians discovered H. pylori, which is the cause of most gastric ulcers. The other major cause being certain medications like aspirin, non-steroidal drugs like Motrin, Advil. But you're right, the whole discovery of H. pylori has basically changed our management of ulcers.
And the other thing I always think about the microbiome is this: I grew up in Wichita, Kansas. So when I went to high school, a third of my friends were small grain farmers like wheat, and a third were cattle, pig, milk cow, whatever. But ever since I was a little kid, every grandpa, every one of my friends' dad was feeding their cattle and pigs antibiotics because they just knew it made them fatter. And then you sit there and here's America with 5% of the population of the earth taking half the antibiotics with the most obese population. And I still know all these farmers. And they still say, well, if I didn't feed my cattle or my pigs antibiotics, they wouldn't be morbidly obese. And so then you start thinking there's some 12,000 known species of bacteria living in your gut. And if that antibiotic is doing that to cows and pigs, isn't it doing it to sapiens?
Yeah, I mean, there's probably something definitely there with the antibiotics changing their flora and changing the way they eat and so forth, for sure. The other factor we have is there's a lot of antibiotic abuse as well. So more and more patients are getting, resistant to antibiotics that no longer work. But there's definitely something there to that story that we need to, discover more. So there's ongoing research in that area.
Well, anything else you want to tell dentists?
I think definitely look for erosions. Maybe ask your patients about reflux disease if they have symptoms, and if they do, I think referring them would be very interesting.
To a gastroenterologist. And what is the website for gastroenterologist? Is there
Well, we have a lot of different societies that they can go to. There's the American College of Gastroenterology. I'm a board of trustees, for them right now. There's the American Society for Endoscopy. There's the American Gastroenterological Association. So there's a variety of different websites that they can go to get information.
So if you're listening right now and you've got photos of GERD and you're a townie, let's get on there. And Lauren's going to become a member, and she'll start a thread. And I hope that we get you all the pictures you need, and I hope that we help you create a scale to measure erosion for GERD. I think that'd be really cool.
That'd be wonderful. Maybe I could post some surveys that you could give patients that only take about 5 minutes to complete to see how many of them really have severe symptoms that are just not admitting it or don't think about it until we ask them.
Absolutely. It'd be an honor.
And then the next step, if we could figure out how to do it, would be to take patients that you see erosions in, but swear that they don't have any symptoms, and, have them come to me somehow or some gastroenterologist and actually see if they have reflux that they're just not reporting. I've done those types of studies before where I've had patients who admit to no symptoms, but when we go and endoscope them, we find precancerous lesions and all kinds of things. So there's definitely a subset of the population who are really truly asymptomatic. And it'd be interesting to look at the prevalence of that in the dentistry world.
Now, does that cross lines with bulimia and purging?
Yeah, I mean, those patients for sure, when we study them, they as they're purging, they're causing damage probably to their sphincter muscle. They're found to have erosions and so forth. And they probably have a lot of dental erosions, I would imagine, too.
Do you see many bulimics?
Some of them, and some of them probably don't admit that that's what's going on. That's, but yeah, I think it used to be more prevalent than it is today.
So is it kind of fading away?
Seems like it's fading away.
Yeah, and there was also a lot more attention to it when Karen Carpenter, probably the biggest singer when we were little kids, with Mr. Postman and all that, when she died of that, that was just a shocking thing. I can still remember, I still remember her being the first, my awareness of it, that someone could literally die from not eating. And just, I remember being a little kid thinking, well, that are you telling me that if she just ate a sandwich, she'd still be alive?
Right.
That was amazing. But you think it's becoming less prevalent?
I'm seeing less of it. I don't know if it's because I'm working in San Francisco or if it's fading, but I don't know the actual data supporting the prevalence of that. Yeah.
Well, it was a huge honor that you came on the show, and I really hope you start this thread, because I really know these dentists on Dentaltown are going to help you get all the pictures and all the stuff you want. And so whatever you need for your dental side, I know the townies will deliver for you.
That would be great. That would be really exciting to publish that, because I think we need more publications in this area. And the other real question is, if these patients have reflux disease, how much should we evaluate them with tests looking for precancerous lesions, and should they undergo procedures to fix it? So that would be really a major accomplishment. I look forward to collaborating with people.
All right. Well, yeah, and you might someday create a course on Dentaltown. We have 275 online CE courses, and they've been viewed almost 1 million times. So maybe when you're doing all this stuff, you might see there's a area in the education deal where we need a course on GERD or something.
Right. Be my pleasure. Yeah. So thanks for having me on the show.
Well, thank you. Thank you very much, and I hope you have a great day.
Great. Thanks. You too.